the thing is this structured essay questions and cases, right? The long cases and short cases. You should not take them as different, because what we check in SCQs and your uh, cases are both similar, have some similarities, where we check your analytical skills, where we check your knowledge, where we check your practical approach. So it has a lot of things to do. It is actually a lot compared to the MCQs. So it's kind of important for you to know. Let me just turn on this light. Right. So it is important for you to know what we are dealing here. Right. So so when it comes to the SCQs and cases, we try to categorize you according to your level of knowledge. So level of knowledge, like cognitive knowledge, your cognitive skills, depends on several things. So it depends on your ability to recall your knowledge or remembering, and ability to analyze and put your knowledge into a practical scenario and evaluate the case and build up a plan, right? And for your ability to compare and contrast things, uh, how to prioritize your differential diagnosis. So these things are going to be important in SCQs and cases. So answering SCQs, I would say take it as for long and short cases, because they usually what they question in a SCQ is something that is going to be important and that can be given as sometimes in a long case, right? So there are several types of questions. So I'm not going too much detail today. So there are essay and structured essay questions. So you probably had essay questions when you were doing your IBSS, right? So actually, most of the time now we have a structured essay question. So you can be have things like write an essay on pediatric hypoglycemia, right? Write and discuss the presentation, evaluation, and management of uh, dengue infection, right? Or in IBSS, you might have things like write an essay on or write an essay on shoulder joint, right? So these type of questions are quite broad and very difficult to structure and give opportunity for the student to write in depth and difficult to mark. And also, student find it difficult to write what is the important things. And as a result, the answers are going to be very diverse, and marking scheme is going to be very diverse. Therefore, sometimes even if you write the proper things, you might not get the marks, and different things can happen. That is why this structured essay concept came into the practice, and it is one of the things that is commonly practiced throughout the world now. So structured essay is something like, you rather than just asking write on essay on pediatric hypoglycemia, they can put something like define, like break down that question into the important parts. So ask define hypoglycemia, list 10 causes for hypoglycemia in 1-year-old child, discuss the investigations and investigations you perform in a 1-year-old child presenting with hypoglycemia, describe the management in hypoglycemia in a 1-year-old child. So basically the same question that is given as write an essay on pediatric hypoglycemia is broken down to 4 components, so that the same things you would be writing in the question for part number 1 will be now be written in four questions, right? So so the questions can be different types. So it can be sometimes problem solving types. So it can be something like where the scenario is given, right? And depending on the scenario, question is given to you. For example, a 1-year-old previously healthy boy presented to the OPD with 2 days of fever and diarrhea and vomiting. After admission, he developed a convulsion. So give 5 possible causes for his convulsion. So it is coming with a problem. To that problem, you are giving some solutions, right? And then outline the immediate management of the child. So then same it can say, so in the stool full report, pus cells are this much, red cells are this, like this. So list 3 possible organisms that can cause the presentation. Describe the management of this child, right? So for 100 marks, again, one problem solving question can be given like this. So what you get most of the time in your final MBBS are questions like this, right? So in your maybe in your module exams, what the questions you get are something like this. So where they mostly oriented towards your knowledge rather than practical approach. But now when it comes to the final MBBS exam, the questions you are getting are likely to be more problem oriented. So there will be a scenario, depending on the scenario, they ask the question. So again, if you look at this type of question, it is more broad now, right? Rather than just asking about hypoglycemia. So within this also hypoglycemia will be a part, right? So when a question is put in this way, it can measure lot of your capabilities, your knowledge, and your integrated knowledge here. So for a question like this, you just need one part of the knowledge in one part, but you need to know because you don't know from where the question is coming. But when the question is given in this way, it has lot of integration among the different parts of the curriculum, different part of the knowledge. For example, here lot of things are asking. So they're asking about the convulsion, they're asking about the management of status epilepticus, they ask the management of hypoglycemia, they are asking about your knowledge in dysentery, right? And this management of dysentery, and lot of things are coming into the picture, right? So structured essay questions are actually more objective and less confusing between the examiner and the examiner's expectation and the student's answer, right? Because you know what to write rather than just a question is given like this, like write an essay on pediatric hypoglycemia, you might miss some of the parts. But when the question is structured, that confusion is less. And it most of the time tests your knowledge, reasoning, and able to recognize the idea, and you really can't do much guesswork there. Because you can do some guesswork, but you need to have some background knowledge to make that guess properly, right? And it is less time consuming to answer because it's more oriented, like more targeted. So you don't have to you are not writing unnecessary stuff. And most of the time, like for example, if you write an essay on pediatric hypoglycemia, like when you put in the questions and like courses, it might take more like longer list or longer like time to write that answer. But when it says list, you just have to list the possibilities, right? And problem-solving type test students' ability to function in a clinical setup, which what we need, prioritize needs, and give focused differential diagnosis and covers a vast range of knowledge. So this is something very important when it comes to the structured essay questions. So when you train yourself for the exam, this is what you need to do, right? This is what you need to do rather than just looking at a topic, get a scenario and try to fit your knowledge into the scenario, right? That's don't this is not the time to just read around hypoglycemia. This is the time to if you get a child with hypoglycemia, see what are the things that in the clinical setup that is being done. So similarly, you can put the question like if you get a child with asthma, see what are the things being done, how the child present, how the immediate management is done, how the long-term management is done, what are the investigations they have done, right? And what are the justifications for those investigations, right? Don't just memorize set of investigations because this is something students get into trouble because there can be variations of presentation. For example, when the child is managed for asthma, sometimes they may have done some extra things because there may be added differential diagnosis like lower respiratory tract infection. For that purpose, they may have done a chest X-ray, right? But unless it is acute severe asthma where you are going into medicines beyond magnesium sulfate, you usually don't do chest X-ray, right, in the acute severe management. But if you have a concern whether there is a lower respiratory tract infection part or collapse, part of the lung have collapse consolidation. So in those situations, you may do a chest X-ray, right? So always, if you find a child in your clinical setup, see why this particular investigation is done, right? So because sometimes the people just do the investigation, just ask your registrars, just ask your HOs in the ward why this investigation is done, why this investigation was necessary in managing this child. So otherwise, you will be getting into trouble when you come to the exam also because you get into a lot of confusions why these things are done. So sometimes you might feel it is not always necessary, right? Have you seen this? Have you seen this hierarchy? Anyone, what is this? Any answers? Yes, this is called Bloom's taxonomy of cognitive learning, right? So this is called Bloom's taxonomy of cognitive learning. This is something you need to understand if you really want a good mark, right? And actually, I think you should have understood it by now for you to create good answer, right? So in the Bloom's taxonomy of cognitive learning, they have described different cognitive domains of learning. For example, remembering is the lowest domain which need the lowest capacity to learn. So remembering is just recalling the fact, recognizing and identifying and make remembering definitions. So this is very primitive level of learning. So you just can't remember things and reproduce. Probably beyond, I think, grade 1 or 2. Even for the scholarship exam, you need more thinking beyond that, right? So remembering is the most primitive level of learning, so which usually humans do in their very early parts of the learning process, right? So the next thing is understanding, right? So still in the question, sometimes they may give things like for the remembering. For example, in this question, define hypoglycemia is a remembering part, right? So it carries very small amount of marks. Again, list 10 causes of for the hypoglycemia in 1-year-old child. Again, somewhat remembering, but again, there is a little bit things like 1-year-old child. So you may need some form of understanding into the situation. So understanding is you need to remember the fact and recognize what is happening there, right? So for this, actually, whether to see whether you have understand, the question can be put summarize, explain, compare, right, classify. So these type of if there are paraphrase, right, this is not happening, this usually does not come in medicine, but usually most of the time the question can be summarized or classify, sometimes explain. So when these type of action words are coming, that test your knowledge on understanding, right? Next thing is applying, right? Next thing is applying. So this is where at least the questions are coming at final MBBS level. It will be minimum at this level. You need to function at least at minimum level of applying if you need to pass the exam, right? If you need to pass the exam, you have to minimum function at the level of applying. So if you just try to remember and understand, probably it is not enough to pass the MBBS exam, right? So minimum you have to be at the level of applying. So you need to apply your knowledge and solve a problem when it comes to the final MBBS. So that's why you get the long cases, short cases, and essay question, and even this single best response questions are mostly functioning at applying level, right? That's why actually now in the world, most of the time the questions are moving from the true false to the applying level, true false to the single best response state, because you need to function at a higher level to answer those questions, right? The next stage is analyzing, right? So if you got a class, right, minimum second lower or second upper, you need to definitely function at level of analyzing, right? So that is where your real knowledge comes into the practice. So that is where you make the differential diagnosis, and you try to you form a set of differential diagnosis, like differentiate, right? You form a set of differential diagnosis and try to prioritize which is the most likely one depending on the evidence, right? So that is actually analyzing. So it is beyond the level of applying, right? So like that, again, in differential diagnosis, you will be organizing in an order, right? So you use your clinical knowledge when it comes to the long case or short case. You use your knowledge on the patient, right? And you tailor-made it to the patient. And what you do is you apply the knowledge and find the clinical findings, and then you have to put into the analysis and come into the differential diagnosis and give the most likely set of differential diagnosis, right? So when the students give about 10 differential diagnoses, which is not even necessary, so we know it is just remembering and understanding level functioning, right? So you have to give the reasons and put the one at the top and see why this is important. So if you really want a first class, you may have to function at the level of evaluation, right? Evaluation, where you critically analyze something, right? You give your reasons and weigh the pros and cons and weigh the risk and benefit and critically analyze your answer and give it to the examiner. So you really need to practice if you really want to come into that level. So it needs a lot of thinking and a lot of practice and a lot of hard work and lot of cognitive processing if you want to function at that level. Final level is creating. Unfortunately, the situation is like most of the time our undergraduate program, even the postgraduate program, does not really come into the generation of new knowledge, right? Creating is generation of new knowledge, right? So this is the highest level of functioning in the Bloom's taxonomy of cognitive learning, which actually should be where the cream of the country should be functioning. Unfortunately, it is not happening due to a lot of practical reasons. But this is where actually I personally believe the doctors, engineers, science graduates should be functioning, right? Where they create the new knowledge, right? When you come to these countries, you will understand actually most of the time the cream of the country will be targeted, like will be trained to create new knowledge. That's why a lot of new things are coming from these countries, not from Sri Lanka, because unfortunately our system is not tailor-made to this level. And not only the system, actually the limitation of the resources and funding, lot of things, right? Right, so this is another one. Actually, now the more understanding is towards this, right? So what I would suggest you to do is find this Bloom's taxonomy of cognitive learning, right? Read a little bit. It is totally worth spending time, half an hour, 1 hour on this, right? And understand what each of these domains tells you, right? Each of domain tells you, and try how you can put these things into the knowledge, your clinical application. Actually, sometimes there are tutorials how to gradually function up to this level. But understand, you must have some facts, you must have some understanding. So it is always going up, right? You just can't start from here. So you need to remember certain facts. You need to have an understanding. Then you need to start applying. So this is the difficult level, starting, analyzing, and coming into the evaluation, right? Finally, up to the level of possible creation, right? Right. So few things when you write the essays and even the your cases, right? Read the question properly, right? Don't. This is some where students, even the postgraduate people, get into trouble, right? They don't read the question properly. They sometimes just overlook the question, just look at the question. What happens is they see something that is in their mind, right? And they produce totally different answer, right? So it is very important, read the question properly. So it gives you guidance what to write, right? And recognize the action words, right? Understand what is the principle of co-knowledge the question is trying to check. If you look at almost all these questions have something co-knowledge that they are trying to check, even at the postgraduate level, right? There is something co-knowledge that they are trying to check. And try to plan your answer. It is totally all right to spend about 5 minutes here. That it will save a lot of your time at the end, right? And do not start with the most difficult or the easiest, right? Keep most difficult for the last, because you like, the thing is, I always keep the difficult one to the last. The thing is, this brain is something that is very like funny organ. So what will happen is, you have the knowledge, you sometimes recognize these things. So once you read this question and keep the question, like, just what I usually do is I get a set of question and just jot down what I am going to write. So when I find the most difficult question, I keep it aside after like jotting down the what I'm going to write. Then what will happen is brain start processing your knowledge and you will be able to produce some answer, even if it is something that is really, really difficult for you. So keep that to the last and don't start the easiest also, because sometimes the easiest and the one you know the most, you sometimes continue to write beyond the time that is given to the question. So what will happen is, whatever you write, like, because the question sometimes you may know a lot of things about that particular thing, but the like the marks allocated that particular question may not be very high. So sometimes, like, when we do the question, you will see sometimes these things like pathophysiology or physiology are asked. Sometimes the students who are very really good at pathophysiology or physiology at the IBSS level or module level, say sometimes start writing sometimes very fine points that carry like distinction marks at the physiology exam, but it is not going to carry you distinction marks at this exam, because sometimes that the same question that is given for like 60 marks at the IBSS will carry only 20 or 30 marks at the final MBBS, right? So it is very important to recognize how much you are going to write, right? So at IBSS, you might spend 15 minutes in that question or 20 minutes in 15 minutes in that question to get 50 or 60 marks. But here for 30 minutes, that question only carry maybe 20 or 30% of the mark, right? There's no point in spending that much of time in this particular final MBBS question, right? So next thing is, so always that question can be from an area that you didn't study, right? But always remember you stick to the basics, right? And remember what you learned from the ward round and classes and lectures, right? So it is very important, therefore, to cover your ward rounds, because there is basically, if you do your final MBBA, final year in the Late Hospital Ward 1 or professorial pediatric unit, or professorial medicine unit or prof surgical unit, basically there is nothing you can miss, right? Because almost everything is there in those wards, and even genomes, all these our professorial wards. So make sure you carefully follow the ward rounds and check the important cases, right? So actually in these nowadays we tend to maintain a whiteboard where we write the important cases if we find, right? Important cases in the sense, not the rare case, right? You know what are the cases coming for your final MBBS. So if such a case is there, just try, right? And see what is happening around that patient and try to go behind the registrars, go behind the echoes and try to learn something, right? So that will save your day at the final MBBS exam, even if you get a case that you didn't have time to study, right? So almost all the questions you get are from something you have seen during your clinicals, right? So we are not going to put, no one is going to put questions that are extremely rare, right? So a few action words. So you need to know these action words. So otherwise you will get into trouble, because if you try to sometime write unnecessary stuff. For example, if the action word is list, you just have to give answer one after another, right? So they don't have to be in paragraphs, right? They just don't have to be even sentences. They just have to be like a few words, right? For example, list the steps of management of hypoglycemia. I would write check capillary blood sugar, send a venous blood sample for plasma glucose, put patient in recovery position if the patient is semi-conscious or unconscious. If the patient is unconscious, treat with rapid absorbing monomers. If the patient is conscious, treat with rapid absorbing glucose monomers, like that. So you write one after another, right? So most of the time list is something when you ask causes, right? Differential diagnosis. So those type of things will be list. So don't try to write unnecessarily wrong answers for this, because for each, for example, sometimes they have 5 courses and carry about 5 marks. 5 courses, 10 marks, right? So they don't carry much mark for each one. So don't spend too much time. So just list. And the important thing is, if you are listing, sometimes most important thing you can put in the top. The next one is enumerate. Enumerate means you have to number it and give. So similar to listing, but you are giving a number. So most of the time it has, if you put the number, there is an order, right? So like this, so you just put the numbers and give the answers, right? Next thing is state or briefly describe, right? So this is in present short and clear format, right? So you it doesn't have to be like pages and pages. So probably if you say state or briefly describe, that means half a page, maximum 1 page. It's not going to be going beyond that, right? So state the management of hypoglycemia. I would say a patient having hypoglycemia can be conscious, semi-conscious, unconscious, or convulsing on the presentation, right? If the patient is semi-conscious, conscious or convulsing, the patient should be put in left lateral decubitus position to prevent aspiration. Capillary blood sugar should be checked. The venous sample should be sent for the laboratory. Right? Urine or blood should be checked for ketones. Right? If the patient is conscious, he can be offered simple glucose to eat or drink, following a more complex polymer glucose or feed that is rich of carbohydrate and lack of fat. Right? So you don't give much reasoning. It is just putting the things in a place. The same things I have written in this format, I am a little bit more elaborating, and I have put it into paragraphs and put into different paragraphs, right? So next thing is describe. So you have to give a little detail and count a full account on the topic, right? So this is again bit of a understanding level question. So you can say same things I have put, but here I am giving a bit of a full account. So if you see here, checking capillary blood glucose is fast and free available method for diagnosing of hypoglycemia. Rather than just saying just to check the glucose, I am just adding a little bit more. And is acute in acute care setup. However, it has limited reliability and it must be confirmed with analyzing of venous blood samples, right? So like that, I am a bit more elaborating, giving some reasons there, right, and putting more weightage into the answer, right? So when it comes to discuss, this is going to be bit of a broad, right? So describe and explain a little bit all right, but it comes to the discuss, you have to give reasons for and against and examine full question and tell the reader about various aspects of, and subtopics with the reasoning, arguments, principle, and can include your own views, right? So that's why that is the difference between the discuss and describe. In the describe, you are not going to put much pros and cons and arguments and reasoning. For arguments, you put reasoning, but you don't develop arguments within your question. Arguments are not something like that you like argue with someone. Argument is scientific argument that is answered within your question, and you put the principles and put include your own views also. So here you can say same thing, right? So the thing I have written previously, in if the patient is semi-conscious, unconscious, or convulsing, the patient should be put on left lateral decubitus position in order to protect the airway from aspiration, since it is deficient of gag reflex, reflex laryngeal closure, and cough reflex and other protective airway reflexes. So I gave a little bit explanation there compared to the previous one, right? And you can say here that checking capillary blood glucose is fast and freely available method. Similarly, I have written previous, right? However, it has limited reliability. Now here I am talking more. Leaking of tissue fluids can make the reading low. Most of the CBS machines boards are not calibrated regularly. So this is something I am putting from my views, right? Presence of sweat and surgical spread can lower the reading than the expected value. Therefore, hypoglycemia must be confirmed by analysis of venous blood sample, which gives more reliable value, as laboratory assessments is subjected to quality control and can be repeated in the same sample, right? So this is the difference between these action words, right? Is the difference between these action words. So you need to understand what these action words says, right? So some other things, define your precise meaning. No need to remember what is in the book, but you have to understand the principle behind it and give the definition. It doesn't have to be the exact book definition, right? Explain, you answer with reasons, right? Compare and contrast, right? It is bit of coming up in the little bit higher level in the cognitive learning, right? Look for the similarities and differences, right? And justify, right? This is something again that comes at evaluation level, right? So you give adequate ground for your decision. You make a decision if the answer, if the question asks justify your answer. So you have to give adequate grounds for your reason, your decision, right? Summarize, right? Trace, summarize is give a concise account on main topic, right? Trace, follow a path of development of something from its origin, right? So these are some action words you need to do, right? Any questions there? Any questions?
Excuse me, sir. If they mean
Yeah.
outline, is it same as
outline is somewhat similar to state of briefly described, right? So you don't have to give much reasoning. You like it is a situation where without much description, without much explanation, you are writing an answer. So it is similar to state of briefly described, right?
Thank you, sir.
Right. Any other questions? Right. Okay. We'll go to the 2015 SCQ, right? Right. Okay. Right. I'm not going to write full question, but like we'll see what the question says, right? Okay, the question one is a 2-day-old baby born at 38 weeks of gestation with birth weight of 3 kilograms was found to have yellowish discoloration of the face and the chest during neonatal examination. The baby weighed 2.8 kilograms on the second day of life. Mother's blood group is O positive, right? So what are the important facts? Like, so just go through the question so you know what we are going to write, right? So you don't just jump the things, right? So first question is asking what are the two most likely causes of jaundice in this baby. So they are going to try to talk about the jaundice in this baby, right? So explain the pathophysiological mechanism of jaundice for the given causes in 1.1. Briefly describe the management of this baby. What is the most serious complication of this baby could develop, right? How would you assess for the complication mentioned in 1.4, right? Okay. So do you have an idea which way this question is going to build up? What is it going to, this question is going to ask? So once you read the up to 1.5, which way this question is going to go? What is the main idea or the core knowledge they are going to check in this question? Lamai. Hmm?
Obviously, they asked me about the neonatal jaundice is
Sorry,
causes.
I can't hear.
Neonatal jaundice. Hello,
Yeah,
sir. Can you hear me? Neonatal jaundice is causes, pathophysiology, complications, and management.
yeah. Basically, you are right. Telling me the questions back, but actually, what they are going to check you is your competence in managing a child with neonatal jaundice, right? And the question is building up from the neonatal jaundice, and you can see going up to the, what is the complication they are asking finally.
Chronic
Connectors. So you need to understand when you are writing the question. So this is the order they are going to follow, right? This is the order they are going to follow, right? So I would just jot down what are the important things here, right? So this 2-day-old baby born at term, right? Birth weight 3 kilogram, current weight is 2.8. Always, if they give this birth weight and current weight, check what is the weight loss or gain, right? So you can see here about 7% weight loss is there on day 2, right? And there's a baby who is having jaundice on day 2, right? And mother is O positive. So these are probably the most important things in this question when you are answering, right? So probably the problems I have seen here are there is a baby who has neonatal jaundice and relatively excessive weight loss, right? Because we expect to have a 10% weight loss by day 7 to 10, right? Out of that 10% on already by day 2, within like 24 to 48 hours. Day 2 means the baby is still not completed to 48 hours. Within 24 to 48 hours, baby has lost 6%, right? Relatively large amount of 7%, relatively large amount of weight loss for a baby who is at day 2. So these are the 2 points you have to understand. So important thing is probably a candidate would probably understand just neonatal jaundice because it is given there. It's nothing to be realized. This needs a little bit of a workup. So this is where actually the like average candidate and good candidate get a difference. Okay, sometimes it's like a person who might not look at this weight loss properly might not pick this up. So this is a baby who has neonatal jaundice plus relatively significant weight loss for the day 2, right? So that is what you have to understand when you are starting the question, right? So what are the two most likely causes for jaundice? What are the answers? What did you write? What are the two most likely causes for jaundice? Anyone?
ABO incompatibility, sir.
Okay. What else? They are asking 2 causes.
Breastfeeding jaundice.
Breastfeeding jaundice. Okay.
Physiological jaundice.
Physiological jaundice. Okay. Any other answers? And if you look at this question properly, what they ask is, what are the 2 most likely causes? Right? They didn't ask give 2 most likely causes. Right? When this article the comes, right, it means in this particular case they are expecting 2 causes only. Right? There are only 2 causes in this baby. They are expecting both the causes from you. Right? It is not there are 5 causes in this baby and they are expecting 2 out of 5. Right? So that these are little bit subtle things you may have to understand when like answering the question. So the way the question is formed in the way, what are the 2 most likely causes? Right? So two most likely causes. So there are only 2 most likely causes in this baby. They are expecting both from you. Right? It is not a situation. This baby has 5 causes and they are expecting 2 out of you. So if in that if there are 5 and they are expecting 2, they would say give 2 causes for jaundice in this baby. So when the article the comes in front of the causes, it means there are only 2 causes in this baby. So you have to give the exact 2, right? Only those 2 are going to give you 10 marks, 5 each probably, right? So if you give 1 and give something else, probably you will get only 5 marks, right? So probably what I would write is hemolytic disease of newborn due to possible ABO incompatibility. The thing is ABO incompatibility. If you give the answer ABO incompatibility, right, I probably will not give you the marks, right? Thing is ABO incompatibility term ABO incompatibility is used with regard to the blood transfusions. If you transfuse a incompatible blood, right? This is not a blood transfusion situation. This is child is developing jaundice due to ABO incompatibility. Right? So you have to specify the answer. So you have to say either neonatal jaundice due to ABO incompatibility, or the more appropriate word is hemolytic disease of newborn due to ABO incompatibility. I would put possible because I don't know what the baby's blood group is. That's why I further modified my answer saying possible ABO incompatibility. Right? The second one, yes, I would write the physiological jaundice. Right? Physiological jaundice, which you might, if you want, you can little bit like modify saying which could have exaggerated following dehydration or inadequate breastfeeding. Right? Inadequate breastfeeding. So here actually you can say breastfeeding jaundice probably might carry some marks, but I would rather write most likely second thing is physiological jaundice. Right? Physiological jaundice, right? Due to dehydration or inadequate breastfeeding. Right? Probably in this case, I would give some marks for the breastfeeding jaundice or even full marks, because most likely at this age, excessive weight loss possibly is due to the poor inadequate breastfeeding, right? So here things like breast milk jaundice will not carry marks, right? Will not carry marks, right? Definitely nothing like definitely not things like uh, uh, neonatal cholestasis, neonatal hepatitis, biliary atresia, very unlikely to carry marks in this situation, right? Any questions there? And this is very important to show your knowledge, right? Probably here, hemolytic disease of newborn. Probably give the examiner, I am dealing with a candidate who know about this situation, right? So sometimes these type of things, how you put the question, sometimes give a bit examiner a little bit of a understanding what sort of a candidate I am dealing with, right? What sort of a candidate I am dealing with, right? Next one, explain the pathophysiological mechanism of jaundice for the given 1.1. What do you write here? It is 30 marks. Now, other thing is, now here actually they are asking the most two likely causes, right? Sometimes they might ask you two causes, right? Always like if next question also look at what they're asking next, right? So because sometimes you might write things that cannot be used to the next answer to answer the next one, right? So it is really important what to write, because sometimes the question itself give you an idea which way this question is going, right? What do you write here? Is the difference between inadequate breastfeeding and breast milk jaundice? That's why actually I said it's almost the same, right? That's why I said like even if you say breastfeeding jaundice, it's fine here. That's why I said you would probably carry marks, right? So, but I would probably put, because breast, sorry, what the question you put? No, breast milk jaundice is something else. Sorry, uh, inadequate breastfeeding jaundice and breast milk jaundice are two different entities, right? Breast milk jaundice occurs, breastfeeding jaundice occurs when there's inadequate breastfeeding, right? Not breast milk jaundice occurs when there is the particular factor in the uh, breast milk that prevents the clearance of the jaundice. So usually breast milk jaundice comes a differential diagnosis when you are dealing with prolonged jaundice, right? Not in the acute phase, right? So in a 2-day-old baby, this is happening because of the inadequate breastfeeding, right? So which is called breastfeeding jaundice, not breast milk jaundice, right? So common problem people face. Breast milk jaundice occurs because of the breast milk causing delayed clearance of the jaundice, right? So what is the pathophysiology you would write here, and to what extent you are going to write? So you can say, see, in this question there are 10, 10, 10, 3, and 30 and 40. So probably this 30 and 40 should carry more time, right? Probably you should be able to write this within like 8 to 10 minutes, and the next 40 minutes question again about 15 minutes, right? So that you carry about 25 minutes, right? And next things you should be able to write in about 5 minutes time, right? What do you write in pathophysiology? So you can take different approaches, but if I am to write this type of a question, yeah, I like two for two. I would initially give a little bit of an explanation about the jaundice or the pathophysiology of jaundice. So I would write not too much. Early neonatal jaundice is most of the time due to indirect hyperbilirubinemia, which occurs when bilirubin production from the red cell breakdown. So before you use a abbreviation, right, always make sure you define it, right? It is a good practice, right? So if you are going to use RBC in future, you just can say red blood cells and RBC, right? Breakdown exceeding the conjugation capacity of the liver, right? So probably these are called topic sentences, right? When you write about something, this is called a topic sentence, right? So this topic sentence give the examiner overall idea what you're going to write, right? So early neonatal jaundice is most of the time due to indirect hyperbilirubinemia, which occurs when bilirubin production from red cell breakdown exceeds the conjugation capacity of the liver, right? So start writing these type of things, because this will improve your English. And one day if you want to face exams like IELTS, TOEFL, OET, these are going to be very important things. So topic 10 sentence, so this gives an overall idea, right? So then you can say heme protein liberated from the lysosomal RBC are converted to biliverdin by heme oxygenase, right? And biliverdin is then converted to bilirubin by biliverdin reductase. If you know this much, you can write, but it is perfectly all right. You can say, if you don't know the enzyme names, you can say heme protein liberated from the RBC is converted to probably I think you know biliverdin and bilirubin names. Biliverdin then to bilirubin by reticular endothelial enzymes in the reticular endothelial system, right? That's perfectly all right. If you know, right, these probably if you know the name of these enzymes, it might carry 1 mark, right? Not too much, right? I won't bother to give too much marks here, right? The bilirubin formed in these reactions are lipid soluble and unconjugated. They are bound to albumin and transported to liver. Right? In the liver, unconjugated bilirubin is converted to conjugated bilirubin by uridine diphosphoglucuronic acid glucuronyl transferase. Again, if you don't know the enzyme name, perfectly all right. You can say is converted to conjugated bilirubin by enzyme system in the liver. The conjugated bilirubin is water soluble and is a water soluble form which is excreted by, right? So probably I would start with something like this, right? So then because it gives me like other than if I start writing to everyone, this bit I will have to write to the both answers. So I would give the initiation like this, then I would jump into the one hemolytic disease of newborn due to possible ABO incompatibility. So you can say what is happening there when the mother and the fetus have different ABO blood groups. The mother can mount an immune response, or you can say mother can be sensitized, right, against the fetal blood cells, right? So fetal RBCs enter the maternal circulation via feto-maternal hemorrhages, right? Then you can say the surface glycoproteins in fetal RBCs are recognized by maternal immune system and mount immune responses against them. So these are a bit funny words you can put, right? These are not things that you don't know, right? But the only thing is like they don't just come. So that's why I say always try to write these type of essays, right? And not detail, but see how you can put in one word, one sentence, right? So you can see when I am writing, I am trying to put like things in like short form, but lot of things in one sentence, right? And mount immune response against them. When the mother has blood group O, this is actually most important two things in the here is this fetal-maternal hemorrhage causing the maternal sensitization, and what I'm going to say next. When the mother has blood group O, the fetus has blood group A or B, the antibodies mother produces get seroconverted to IgG, right, which could cross the placenta, right? Whereas in the mother is A or B positive, what happens is these antibodies are IgM, which does not cross the placenta, right? That's why this ABO incompatibility occurs most of the time when the mother is O, whether has the O blood group, right? So if the mother has O blood group, the antibodies she produces are of IgG type, so which can cross the placenta. Probably actually the whole answer, this is the most important point, right? Whole answer, this is the most important point and one of the most important points also, right? Then you can say the maternal antibodies that enters the fetal circulation bind to RBC surfaces. If you remember the word, you can write the opsonization. These are words you have learned in your past modules, opsonization and subject to extravascular hemolysis, right? So actually it is just impressing your examiner. Just put in that rather than just putting in hemolysis, I say extravascular hemolysis. I say binds and opsonizes, right? So if you write these things, it becomes like more palatable to read for a examiner and like just give the feeling this like to give some more marks. And even if you lose some small areas, right? Like even if you don't remember the like heme oxygenase, biliverdin reductase, right? UDP glucuronide transferase, right? Like these type of things, this opsonization, extravascular hemolysis, right? Glycoproteins, right? Fetal-maternal hemorrhage. So these type of things, and IgG, which could cross the placenta. So these type of things make the examiner like try to give you more marks, right? They tend to give you more marks if you try to do something like this. So when the rate of hemolysis is sufficiently high enough to produce bilirubin at a rate that cannot be successfully conjugated and excreted, the baby develops jaundice, right? So probably that what I would write for the hemolytic disease of newborn due to ABO incompatibility, right? So next one, physiological jaundice, so which is exaggerated by inadequate breastfeeding or dehydration. What would you write? Hmm? What would you write? Anyone? It is very common thing. What would you write? Actually, if you look at this question about that 30 marks, probably ABO incompatibility would carry about 18 or 20 marks, right? Rest of the 10 would carry it by the physiological jaundice part. I want to show is like, it's most of the time it happens. The physiological jaundice happens due to two main reasons. One thing is the fetus has high hemoglobin mass, right? Which is not necessary after the birth. So what will happen is there will be a rapid red cell turnover, increase in the bilirubin production. And the second thing is neonatal liver enzyme system and the transporter system is not very mature, even in the term babies. So liver is unable to handle the bilirubin load, right? So you can write up to that. So few things you can add when the baby is dehydrated. So this is where the exaggeration part comes, right? Baby is dehydrated. What will happen is the blood volume contracts, right? And bilirubin concentration will increase, right? So it will be more pronounced then, right? Then further, when the blood volume is contract or volume is low, what will happen is the rate of bilirubin and glucose delivery to the liver will reduce, and it drops the conjugation rate. Right? So these are few things you can add, right? And when the baby is not fed adequately, what will happen? The glucose supply that is necessary for the glucuronization step and conjugation is less, right? The final what you can write is when the breastfeeding is inadequate, the motility of the bile contained stool across the gut is reduced, increasing the chances of enterohepatic circulation, which delivers the bilirubin back into the circulation. So these are few additional things you might write for the answer if you really want to carry some extra marks and here, right? Probably up to here, if you write, probably it should carry about 6 or 7 marks, right? So these might carry additional 4 or 5 marks. That's why I didn't want to put too much effort onto that, right? Any questions there? Any questions, Amay?
Excuse me, sir, can you explain why they mount IgG response in O mothers, but IgM response in A and B?
Well, it's like a finding. The thing is like they only do the seroconversion from any time. If you like get sensitized, what mount first is IgM, then it got seroconverted to IgG, right? But the thing is, it happens, this seroconversion to IgG happens only when you have the O blood group, right? So that's why the mothers who are having O blood group are the one who produce the IgG that can cross the placenta. So when the mother has blood group O only, or most of the time O is the one that gives rise to the ABO incompatibility. And when the mother is A or B, they most of the time produce IgM. Very rarely only they produce IgG. That's also only by the B mothers, right? So if the mother is A or B, they don't produce IgG, which just does not cross the placenta. So if the mother is A or B and the baby is B, they may not develop, they are very unlikely to develop ABO incompatibility. But if the mother is O and if the baby is A or B, then they can develop ABO incompatibility because then only mother has IgG in their blood. And because IgG cross the placenta, but IgM does not cross the placenta, right?
Thank you, sir.
Okay. Any other questions? Right. Briefly describe the management of this baby. What do you write when they ask to describe? the management. If they are asked to describe the management, what are the aspects you are going to write in the answer? If any time a question comes, describe the management, what are the things you are going to, how are you going to answer the question? Right. So few, like most of the time, like adhere to the same thing, like look at the history, because there can be parts in the history that is necessary, right? See whether there's anything you can add from the history, right? And examination part, if there's anything that you need to do additionally, right? And investigations and necessary pharmacological or non-pharmacological management and follow-up, right? So actually what is necessary is management of this baby. Usually it asks about acute management, right? So what I would write is, so you have to look at obtain the records and look for the risk factors for sepsis, hypoxia, and check for the mode of delivery, right? And check nursing notes on feeding, bowel movements, and urine output. Because I am dealing, sometimes you might forget this baby is someone who is now having actually a bit of a significant weight loss, right? So this part I would write, right? And then you can obtain history from the mother regarding family history of jaundice in the previous babies, right? And feeding adequacy and maternal competence on the feeding, right? So you can add other things. The mom has fever, it's perfectly all right. So whatever things that is necessary for the management of this baby, right? Then examining the baby is important. Baby, look for the clinical signs of dehydration, sepsis, low glucose, hematoma, or bruises. Because if there's a hematoma or something, that can again exaggerate the jaundice. Because of these places, again, there's going to be increased amount of hemolysis, right? Then the most important aspect is this: check the total and direct bilirubin, right? And plot the total bilirubin value. Here, important you to write, don't write plot the bilirubin, not the direct bilirubin, but not the indirect bilirubin, but you plot is total bilirubin, right? Value against the age, right? Okay, and you can further qualify your answer saying against the age in hours, right? That's how the neonatal bilirubin nomogram has made, right? In the neonatal bilirubin nomogram, or you can say the Lilly's nomogram, right? At the same prick, you can perform the baby's blood group. So it is going to be important now because mom is O negative, O positive. Full blood count and blood film. You can write full blood count and blood film looking for features of hemolysis, right? Serum electrolyte is going to be important in this baby because because the babies who are dehydrated in early part, they can develop hypernatremic dehydration. So electrolyte is going to be important, right? And glucose, right? So it is going. Those are the important investigations you may have to write, and you can add. You can do CRP and blood culture if there is concern of neonatal sepsis. And I got another one, right? Yeah, sorry. And if the baby has A or B blood group, request Coombs test, right? Request Coombs test. So the thing is, regarding the breastfeeding technique, you can write here. You can assess in the examination class. You can write. You can assess the breastfeeding technique and the positioning of the baby, but you don't have to go to in detail, right? Because otherwise you won't be finishing this answer, right? You can check. I am briefly check you. I will assess the breastfeeding technique and positioning of the baby, right? So the next thing is like, because this question is going to have more gravity on this investigation part and the management of hypobilirubinemia. So if the baby carry 40 marks, right? Phototherapy should be initiated depending on the severity, the number of units you can decide, right? So you can say the baby should be in the center of the light field and should be ideally 45 centimeters from the phototherapy lights, right? And if there's a belly blanket available, you can use the belly blanket, right? Baby should have minimal clothes, right? You can say the eyes are covered, right? And if single phototherapy is used, baby should be turned every 1 to 2 hourly to maximize the exposure, right? If baby is needing more light units, the phototherapy cot can be covered with glazing or reflecting blankets, right? To increase the phototherapy efficiency, right? Once actually I had to use, because these blankets are not available, what I did was I used these aluminum foils that is being used for the cookery, right? So I covered the whole cot using aluminum foil, so it will reflect the light back into the baby, right? So actually, if you use something like that, it can increase the phototherapy efficiency by about 75%, right? Then the most important thing is the bilirubin level should be monitored every 4 to 6 hours to see whether it is dropping, right? If it is dropping, phototherapy can be continued. If it is rising, exchange transfusion should be considered, right? If the initial bilirubin is above exchange level, still the triple phototherapy can be started, provided that it drops rapidly and baby does not have features of encephalopathy, right? Then if the phototherapy is not successfully dropping bilirubin, IVIG can be considered as a exchange transfusion sparing therapy. For other options, you can use albumin and fresh frozen plasma to increase the bilirubin binding to albumin, right? If exchange transfusion is impending possibility, baby's umbilical cord should be kept wet, right? So I would be really happy to see a quick answer like this, something like this, right? Because it says me this person has a practical knowledge, right? Because for you to do the exchange transfusion, either you have to have a central venous access or a peripheral venous access plus an arterial access, or you should have the umbilical cord access, right? So it is very important by the day 2, this umbilical cord start getting dried. So what you can do is you can use a saline soaked towel, putting on the umbilical cord, right? Putting on the umbilical cord to prevent the umbilical cord getting dried up, right? Umbilical cord getting dried up. So it is going to be very important intervention in this type of babies, which can send the umbilical cord is available for the access. Oh, it is really easy to access. Umbilical cord is really easy to access compared to arterial access or central venous access, right? So if you write something like this, I know this person has been working in the board, right? And then what you should do is the baby should be assessed by consultant pediatrician or neonatologist prior to the exchange. External transfusion should be carried out with plasma cross-matched to the mother and the RBC cross-matched to the plasma used, right? This is done because, sorry, I think I wrote in the wrong way. Red cells cross-matched to the mother, right? Red cells cross-matched to the mother and plasma cross-matched to the RBC, right? Red cells should cross-match to the mother and plasma should cross-match to the RBC in order to prevent further hemolysis, right? So careful monitoring is necessary for hypoglycemia, hypothermia, hypocalcemia, and acid-base balances. Probably I would write that much during this part, right? You don't need to do, but you can say you can use a double volume exchange transfusion here. If you that also would carry a little bit of mark if you write about this, right? Then the important thing is a feeding, right? So during the phototherapy, feeding should be continued. Phototherapy can be disturbed for breastfeeding, right? However, if the phototherapy takes priority, baby can be cup fed or tube fed, right? If the feeding is inadequate, then you can say you can go for the receive express breast milk or formula milk in this situation, right? When the feeding is inadequate and baby should be on IV fluid according to the neonatal fluid cocktail, which contains adequate glucose, right? There should be 10% fluid allowance for each phototherapy unit, right? And baby should be monitored with heart rate, respiratory rate, saturation, and temperature, right? Probably this is the amount I would write for this question, right? Any other things you would add? So neonatal topics are going to be very important in your paper, right? You can see like at least 3 or 4 SBR questions are there from the neonatology, right? And almost every year there is a full 1 question from neonatology, right? And definitely in the true false also 1 or 2 questions are there. So there is a significant weightage for the neonatology. So neonatal topics you should definitely cover, right? So prematurity, feeding, sepsis, neonatal hemorrhagic disease of newborn, which has not tested recently, right? So these things are going to be important topics, right? Make sure you go to the neonatal guidelines by the ministry. So those are, I think, you can download from the Paediatric website, right? Just if you just do a Google search neonatal guidelines from the Sri Lanka neonatal guidelines, you can find there are 3 books, right? All 3 are available free to download. Make sure you read those things and make sure you cover those areas, right? Yeah. Can you explain the 10% allowance of the hydration? The thing is, when you put on the phototherapy, it increases the evaporation of the body fluid, right? Or increases the insensible loss. What you do is, so from like you calculate the baby's daily fluid requirement. I think you know how to calculate. Usually, if it is for a tame baby, for day 1, 60 ml per kg, for day 2, 80 ml per kg, both for day 3, 100 ml per kg, right? For day 4, 120, 110, 120, day 4, 140, day 5, 6, days 150, right? So you calculate the total daily fluid requirement, right? And for example, in this baby, this is day 2 old baby. So the baby's fluid requirement is, this baby's birth weight is, you calculate it for the birth weight. So baby's birth weight is 3 kilogram. So baby's daily fluid requirement is 80 into 3, that is 240, right? So that is a normal requirement for a baby who is not on phototherapy. So when the phototherapy, if the baby is on single phototherapy, so you have to give additional 10% allowance. So 10% allowance is 10% into 240. That means additional 24 milliliters you have to give, right? If you give the baby on double phototherapy, additional 48 ml you have to give. If the baby you put on the baby on triple phototherapy, additional 72 ml you have to give, right? So that's how you calculate the fluid allowance, right? Any other questions there? Any other questions? Right. I would write up to here. Right. Next question. 1.4. What is the most serious complication that this baby could develop? What is the most serious complication that this baby could develop?
Connectors.
Okay. Yes. Actually, I would write for this type of answer. I would write connectors, which if left untreated can lead to death, because death is more serious complication, right? Which can happen from connectors, right? I would probably write in this type of situation, connectors, which if left untreated can lead to death, right? So how would you assess for the complication mentioned in 1.4? How would you assess for the complication mentioned in 1.4? Actually, what they're asking is connectors, not the death, right? So if someone asks you what is the pathophysiology of connectors, how would you build that answer? So go home and see how we're going to build that answer, right? If somebody asks the pathophysiology of connectors, right? So how would you assess the child for the developing of the connectors? You can see actually the connectors assessment itself is like maybe 25-30 mark section, right? But they give only 10 marks, right? Probably that is because this is a bit of a serious complication that may not be really expecting from HO to assess, right? And this type of a baby should be under the care of pediatrician, but you need to know something about assessment of the complication of this complication. So actually diagnosis is clinical, right? So assessment is very initially what these babies develop is they start feeding poorly and become less active. Those are subtle, like early common features for encephalopathy as any babies, right? So they started becoming feeding poorly, they become less active, then they may develop high-pitched cry, right? So, and then the thing is, when it is progress, they will lose the Morose reflex, right? They will lose the Morose reflex. If you really see that, that is like you are a little bit too late, right? It will be too late, right? So you have to catch it at the point where the baby start less active, poorly feeding, becoming lethargic, right? And having a high-pitched cry. So if you let it to the point of losing the Morose reflex, that means already bilirubin has crossed the blood-brain barrier and start depositing in the basal ganglia, right? So if it further develops, what will happen is baby goes into the opisthotonous posture and they lose their tendon reflexes, right? They lose their tendon reflexes, right? So if it is further severe enough, sometimes they can go develop the seizures, right? And causes lifelong complications. Finally, it is the early part. Then they gradually develop choreathyroid and choreathyroid spastic quadriplegic cerebral palsy, which is a very disastrous situation, right? So you should minimum definitely catch this at least at the level baby is having poor feeding lethargy and less activity, right? You should not let it to the point of lack of Morose reflex, right? So that is the most important thing. So don't neglect these babies because this is a very disastrous complication. Like there are a few babies who were at LRH Ward 1 follow-up who had kernicterus. 1 or 2 babies were there. I don't know. One baby was there, whether he's dead now, right? At least there's another child, right? If you see it, you will see how pathetic situation that is, right? We really can't do anything once they develop kernicterus, right? So it is very important. Jaundice is nothing to be taken lightly, right? And don't never ever tell this is if a mother brings your baby or midwife send the baby saying that this is jaundice, don't go for the visual assessment, right? Important thing is don't go for the visual assessment because again somebody can put a question, right? If I am to put a question, I would rather put a question, explain why visual assessment of jaundice is not a reliable method of checking the degree of bilirubin level in blood, right? Go and find the answer why visual assessment of the baby is not a reliable way of assessing the degree of hyperbilirubinemia, right? Sometimes, like in the past old ages, they tend to say if it is just in the eye, it is just in the eyes or face, it is mild. If it is up to the abdomen, it is moderate, and if up to the mid thigh, is moderate to severe, and if it is up to the feet, that is severe. So that is not valid anymore, right? And go and find out why, even with the very high bilirubin level in the blood, right? Baby may have jaundice, may have features of mild to moderate jaundice clinically, right? Go and find out why it happens that way, right? Okay. Any other questions from here? Any other questions? Right. Do you want to discuss the next question? But it's too late. ළමයි මේ බැච් එක කතා කරන්නේ
Anything, okay, we can go for the next question.
Sorry?
Anything, sir. We are finding it.
Okay, shall we discuss, like, we'll see the first part of the question 2. The second part, 2.2, is like completely different one, right? So let's see how long will it take for us to go to the like 2 up to 2.13, right? Right. A 2-year-old girl is admitted to the pediatric emergency unit with a history of 2 episodes of target color stools and 1 episode of hematemesis, right? She was diagnosed as having biliary atresia at 1 month of age and underwent Kasai portoenterostomy. Her clinic records shows that she was seen in the clinic only once after surgery, right? The mother says that she could not attend the clinic due to COVID-19 pandemic. At the emergency unit, the child looks pale, having grade 2 clubbing. Her pulse rate is 120 beats per minute. The blood pressure is 60/40. The abdominal examination reveals 3 centimeter spleen and shrunken liver. Right? So what do you get from this? Like, we'll go to the question. Briefly outline the immediate management of this child. Discuss the pathophysiological basis of the hematemesis in this child. List 5 important steps in long-term management of this girl. Right? So this is a question actually coming from the post-Kasai surgery. Last time actually I told the students to go and read. There's a article by Prof. Shaman Rajendrajit in how to manage Kasai children and post-Kasai management. There was a nice article written by him and Prof. Naresh Shanmugam to the Sri Lanka College of Paediatricians, right? In the Journal of Sri Lanka College of Paediatricians. So actually, it has everything. And basically, it has everything, right? I'm not too much familiar about the other journals, but actually Sri Lanka College of Paediatricians journals has very nice articles, right? Very nice set of articles that is necessary for the management of these type of babies, right? Therefore, make sure you go and read these things, right? Okay. So what do you get from this question? Which way this question is going? So basically for the 50 marks, basically it covers a lot. Right? It covers the acute management, it covers the pathophysiology part, and it covers the long-term management part. So just before jumping, for the question 1, so once the baby is discharged, so baby is successfully given phototherapy, no kernicterus, and baby's blood group is A positive, right? Found to be A positive, ABO incompatibility, nicely managed at the neonatal unit, and they are going to discharge, right? So go and find out how are you going to follow up that baby. Right? So are you going to just discharge, or are you going to arrange some follow-up? Any medications you are giving to that baby on discharge, right? So make sure you find the answer and write an answer, and you can get one. You can discuss with your registrars or whoever, right, or among yourself, and see what I'm going to do when you are following up that baby. So that may be the next SBR question next year. An ABO incompatibility baby being discharged, having with some particular thing, and what I'm going to do, right? Find out why you do that way, right? Okay. Okay, for this question. So looking at the scenario, what is this child having? What does this child have? What does this child have?
Child probably has developed into chronic universal disease, and with
Child probably has what?
Into chronic universal disease with portal hypertension as a complication of biliary atresia.
Yes, this child likely has chronic liver cell disease. Actually, you can say it's even cirrhosis now, because liver is shrunken now. Like, liver has gone into cirrhosis, right? And child has portal hypertension. Why do you say this child has portal hypertension? Why do you say this child has portal hypertension?
Child has developed hematemesis, and there's evidence of
okay, the one thing is this child has developed hematemesis. Second thing is
splenomegaly.
Yes, splenomegaly. Right, good. Right, splenomegaly. Right, because spleen is enlarged as a result of splenic congestion because of the increased portal vein pressure or the portal hypertension. Right. So if I ask you to give what is the final like complete diagnosis, what would you write? Or I would ask, what would you write in the diagnosis card or the diagnosis card in this child when this child is going home? What is the complete diagnosis you would write?
Chronic liver cell disease with portal hypertension due to failed CASI.
Okay, chronic liver cell disease with portal hypertension due to failed CASI. So I would further write little bit try hematemesis following variceal bleeding in a child with cirrhosis with portal hypertension following failed CASI procedure. Right? So it is failed CASI now. Right? It is failed CASI. So about the CASI procedure, what is the success rate? What is the success rate?
About 2/3.
How would you really give the answer if somebody asks this question from you? The success rate of CASI procedure?
1/3 will not. We have resistant jaundice and the procedure will fail, sir.
Sorry, I don't hear you. 1/3 will?
1/3 the procedure will fail and persist will have symptoms and jaundice. Another 1/3 can live for a bit of long period up to 70s without liver transplant, and the other 1/3 will require liver transplant like in few years.
Well, actually, what say usually say is 1/3 is fully successful, 1/3 is partially successful, and 1/3 fails. Right? Fully successful in this 1/3 fails means what do you mean by fail CASI? What is a successful CASI? What is successful CASI procedure? Okay, go and read Prof. Salmon's article. It has all these answers, right? What is successful CASI? What is partially successful CASI? What is fail CASI? Right? What is fail CASI? Right? Okay, so what happened in this child now? This child is coming with hematemesis, right? And what is the situation this child is in now?
Hypolimic shock.
Hypolimic shock following hemorrhage. So briefly outline the immediate management of this child. So outline, so you can even like when it say outline, you can either go for the like short paragraph, or you can even go to the sentence point form in sentences, right? What do you do? 20 marks. How would you write for any emergency, or even if you are managing any emergency, how would you approach? So basically they have given
starting with the ABCD management.
I can't hear. Starting with the
ABCD management, sir.
Okay, ABCD management. Okay, what would you do? How would you do in this child? So you have to tell me how would you apply that knowledge in this child. Okay, so this is a question coming at the applying level now, right? So you can say, okay, you assess the ABCD, you talk to the child and see whether they have this pattern, right? You see whether the child is breathing and breathing is adequate, and they have already given the circulatory parameters, right? And you can say what the consciousness of the child, and same time you can say, I will check the blood glucose. So D goes with glucose, and expose and see whether the child has any obvious hemorrhages, right? So you can tell that part, right? Then probably that would carry about 3 marks out of the total. Next, what I'm going to do? 3 or 4 marks. Next. So you do the ABCD assessment, then lamai. So after the ABCD assessment, what is the next important thing? Sorry, yes, Dura.
Blood for investigation.
ළමයි cannulate කරන්න ඔක්කොටම කලින් next important thing is you have to decide how you are going to position the child, right? So positioning is the next most important thing. How you are going to position this child and where you are going to keep this child.
Child should be kept in the acute side with acute
acute side. ඔය කටපාඩම් කරලා යන්න ගියාම වෙන්නේ. This child is in the emergency unit, not in the ward. Right? So you have to have a bit of knowledge how the emergency unit works. So you have been to the PAU in the LRH. Right? So how are you going to position this? Where are you going to keep this child? So is this that at this moment, is this a child who needs the most attention or least attention?
The child needs the most attention.
Just need the most attention. So we are going to keep this child. Are you going to keep this child in the corner of the emergency department or close to the nurse's station and the doctor's station?
Close to the nurse's station.
Closest place to the nurse's station with a direct observation. Right? So you, with the direct observation place, you can directly observe the child close to the nurse's and doctor's station. Right? What is the position you are going to keep this child?
Position, sir?
No.
Left lateral position.
No.
Semi-cross.
Why? When do you put the child in a semi-lateral or actually it's not the lateral position, it is lateral decubitus position. So head has to be more low. In what situation you are going to put the child on decubitus position? ළමයි.
In a seizure, sir.
Yeah, when the patient has low GCS, where the airway reflexes are not optimal, right? You put in the patient in the left lateral decubitus position, right? Give me a situation you put a patient in a right, like left lateral or right lateral semi-decubitus position, not decubitus, like just lateral position. Just you turn a little bit laterally. Not pediatric. If I further help.
Pregnant mothers.
Yes, sorry.
Pregnant mothers.
Excellent, very good. Pregnant mothers, right? Especially in situation if you are doing the C-section, right? So, or in situations when you are performing cardiopulmonary resuscitation in a pregnant mother, that is to get the gravid uterus out of the inferior vena cava, right? So in those positions, you give a slight tilt, not a full turn position in the bed, right? So when do you prop up the patient?
If a patient is in respiratory distress.
Yes. What is the idea of propping up? Why do you prop up?
In supine position, there's pulmonary congestion.
Sorry. In supine position.
There'll be more pulmonary congestion with increased
No. These ideas actually are simple. You prop up the patient to take the abdominal viscera out of the diaphragm. So the diaphragm will not be pushed up, right? And diaphragm has more space to work. That's why you prop up the patient, right? This patient, which position do you keep? This patient does not have any of those. But this patient has a hypotension. What you should do? What happens if you put this patient in proper position?
Brain perfusion will reduce.
Yeah, brain perfusion will reduce, right? Brain perfusion will reduce. So what you should do this patient?
Can elevate the limbs.
Either you should put the patient in the flat lie down position, you can elevate the legs, right? That is the position you are going to place this child, right? So very important when you are answering these acute emergencies, right? Always position has lot of things to do, right? Don't like blindly say prop up and give oxygen left lateral and this thing suck out the secretion, not always apply. So in this, particularly in this child, there's no place for prop up, no place for left lateral, no place to suck out secretions, right? So this patient has to be on lie down position with legs elevated in order to take the venous circulation back into the heart, right? You have to optimize the central circulation now, right? So next only you are talking about the things we are going to do. What we are going to do next? So again, you can go over ABC. Anything else you can do?
Start oxygen.
Start oxygen, right? Quickly you can do, and you lie down the patient and start oxygen because child is in circulatory shock. You have to optimize the oxygen delivery by giving more oxygen and increase the oxygen binding, right? Next.
Cannulas and blood facility.
Okay, cannulas and bloods. How many cannulas?
2 white bow cannulas.
Okay, what is the white bow cannula color?
Blue color.
Very good, excellent. Pediatric white bow is blue color, right? You can go for the yellow, sorry, you can go for the things like pink if the child was old enough, but this is a 2-year-old child. You have to minimum put 2 blue color or 22 gauge cannulas, right? And while cannulation, so those are the steps you write. So you do the ABCD assessment, position, oxygen, now you cannulate, right? 2 cannulas, what are the bloods you take? So you have only very small blood coming. What is the investigation you would send?
Grouping and
DT.
Very good, grouping and DT, right? So always start writing in that way. So that the examiner knows this person knows things, right? So that's how you outline the thing. So you get the blood and send for your number 1, you can say grouping and DT, grouping and direct test or grouping and cross match, right? Then other things what you would do. If the bloods are enough, second test, what is the test you would do? If you haven't checked glucose, here's the point. You can check the glucose, right? Next one. Next ones.
PTINR levels.
All right. Okay. I would rather send it to the electrolytes, right? Electrolytes, PTINR, ALT, albumin, full blood count, right? Anything else you would say? Anticipating some problems?
VBG.
Good. Very good. Venous blood gas, right? You would send a venous blood gas. Actually, if you don't have blood enough, other than sending anything else, you can send a second sample for the venous blood gas. Because venous blood gas itself gives you not only the pH, bicarbonate, and carbon dioxide, it will use the current blood gas machines give you glucose, lactate, electrolytes, calcium, chloride, and some of them can give you even blood urea creatinine values too, right? So actually everything can be covered by a single blood gas, right? So if you don't have enough blood, I would probably send a grouping DT, venous blood gas, and glucose and venous blood gas. That's the rest of the things, right? Okay. So once you take the blood, next what are you going to do? So here this question is outlined. So you don't have to tell things like I would call the laboratory and trace the sample immediately. I will arrange somebody to carry the sample to the laboratory. So those things, type of things are not necessary when the question is outlined, right? Those are additional things you can write in the question like discuss or describe, right? Next what are you going to do? So you are just lining the most important points now. Next what are you going to do?
Start crystalloids.
Okay, good. Start crystalloid. What do you give? How much you give? I give the full answer. That's the important thing, right? Are you going to give crystalloid as an infusion?
As a bolus, 20
as a bolus. How much do you give as a bolus?
20
How
milliliter
much?
per kilogram.
Okay, right. I would give marks, but I would have to give more marks if somebody give a more like precise answer.
As a free flow.
Okay. So actually, current recommendation when you are managing with the bleeding, right? You give 10 ml, 10 ml aliquots, right? You have to give 10 ml, 10 ml aliquots, right? So you give 10 ml and see whether you can reverse the shock, and you give another 10 ml. You can give as a free flow bolus, it's fine, right? You give 10 ml because the thing is, if you overcorrect, what will happen is this: the blood clots that prevent bleeding that can get dislodged, right? That can get dislodged. So one thing is you start the crystalloid fluid, right? You can, how many boluses, how many fluid correction you can give with the crystalloids? And how would you
40
modify this
milliliters
answer
per
here?
deciliter.
Sorry?
Up to 40 milliliters per deciliter.
Yeah, that is the recommendation. You usually go up to 40 milliliters, but the situation actually in a bleeding situation, if you have O negative bloods in hand, and if you can't correct and if the child is, this child is actually not that much of bad shock, right? You can actually assess the situation with the blood gas lactate. If the child is having high blood gas lactate, metabolic acidosis, and this child has a recordable blood pressure, unrecordable blood pressure, right? So if those situations are there, I would rather go for the O negative bloods, right? But since this child has recordable blood pressure and tachycardia is not very bad, probably I would initially give 10 ml, 10 ml 2 boluses and see what is happening, right? Next, what I'm going to do? You give about 10 ml bolus, 10 ml bolus, and blood pressure is all right. Okay, you monitor that. Other thing you should always tell is after each intervention, you are rechecking the blood pressure, right? So what I'm going to do next?
Maintain input-output charts.
That is not acute management actually. Acute management is the stabilizing the baby, is stabilizing the child. So next important thing here you have to talk is a blood transfusion, right? You can't neglect the blood transfusion in this child because she had 2 TAR stools, 1 hematemesis, and circulatory shock. So it is due to the loss of blood. So you should not, you are just gaining the time by giving crystalloids, right? But you have to replace the whatever the blood. So what you have to say is if there's a delay, you have to give O negative blood, otherwise you give the cross-match blood. At least 5 ml per kg or 10 up to 10 ml per kg blood transfusion. You have to give minimum 5 ml per kg blood transfusion, right? Next, what I'm going to do? What is the other step in this? So up to this point, up to blood transfusion point, everyone should be able to write, right? Up to that point, all the points you should be able to write without losing anything. And probably the next few points may be the one that differentiate between class, distinction, right? Higher marks. What else you would write here? Another thing what you should do here, other blood and something else.
Teliprecin octreotide can be used.
Okay, before octreotide and things, anything else you would do?
Bacterials.
Those are bit of chronic management. Stabilizing parts. Few things you forget here. You can give tranexamic acid, right? You can give tranexamic acid for the stop the fibrinolytic pathway, right? And you can give vitamin K in this situation because it is liver, right? You sometimes there can be vitamin D deficiency, vitamin K deficiency. Additionally, you can talk about if the INR is prolonged, considering FFP, right? And additional points you can add here are things like considering activation of the rapid massive transfusion protocol. So if you write something like massive transfusion protocol, that is a plus point. I would activate the massive transfusion protocol, right? Then you might write for this much, you should be able to write if you want something like 60% of the marks, right? So up to the what I told previously is the average mark, right? So up to this point, if you write, it is 60 to 60, like second lower mark, right? So if you want more, what you would write? Somebody came up with the answer. Yeah, what is it? What else you would give?
Octreotide and autorepressive. Octreotide autorepressive.
Yeah, you can try give the proton pump inhibitors and octreotide particularly because which say shrink the splanchnic circulation. If you don't have octreotide, you can go for something like terlipressin, right? So and then what would you write?
Urgent upper ear endoscopy and banding if stable.
Yes, you have to refer to the surgeons for urgent upper GI endoscopy, banding or sclerotherapy. Plus, you have to keep the child nil oral, right? So that would be the full answer I would write in this situation, right? Stepwise, you can write up to that, and that is where the endpoint therapeutic endpoint, and that would be the therapeutic medical therapeutic endpoint, but still the not the surgical therapeutic endpoint. So that is the what would be the medical therapeutic endpoint, right? Any questions there? That always bring this structure when you write it, right? ABCD positioning where you keep the child, right? Stabilizing the systems, right? And how would you stabilize? Don't in this child you should not stop by the giving the crystalloid fluid. You have to go for the blood, right? You have to go for the tranexamic acid. You have to go for the vitamin K. You have to consider FFP, right? And you have to consider. You have to give octreotide, proton pump inhibitors, and surgical referral for banding, right? So can you explain the crystalloid part again? The thing is, that especially in situations of bleeding, right? You are not going to correct it by giving crystalloid only, right? This is because the pathophysiological rationale behind this. Because what is the oxygen delivery equation? Oxygen delivery equation. So it is a stroke volume into oxyhemoglobin concentration, right? So there's no point just correcting the stroke volume only, right? You have to correct the oxyhemoglobin part also. That's why you give oxygen. But still, if you don't have enough hemoglobin, you have to give hemoglobin into the blood system, right? Otherwise, the organs, like what will happen is you will pick up the blood pressure, but still the organ will suffer the hypoxic injury, right? You will pick up the blood pressure by giving crystalloids or sometimes colloid, right? That's why actually they don't ask not to give colloids, right? What will happen is the systems still will suffer hypoxic injury. So it is very important in these situations you give hemoglobin into the systems. Otherwise, even with the normal blood pressure, the system will suffer hypoxia, right? Right. Next question. Any questions there, Laman?
So is there a place for IV antibiotics here?
Not really, because it's all right to start, but it won't be a part of this particular management. We usually sometimes start in these situations, but it is because of some other reason, but not to cover this, right? So it's actually there's something called golden therapeutic window of acute on chronic liver failure, right? So that's why actually we start antibiotics particularly because of this. And actually in these type of situations, sometimes you can't go by the CRP also because CRP can elevate it following hemorrhage, right? Any other questions? Right. Discuss the pathophysiological basis of hematemesis in this child. What would you write? What would you write here? It is only 15 marks, right? You can see you don't have to go into detail like previous one, right? So probably don't try to spend too much time on photosystemic anastomosis, right? Writing where what really happens, where these are, because this is most of the time this in this child it is hematemesis. So from where it is bleeding now.
Gastroesophageal junction and the fundus of the stomach.
Yeah, it's mostly the lower esophagus, gastroesophageal junction, and the fundus of the stomach. So those are the three areas. Those are where the varices mostly form, right? So what I would write here. So you have to write a little bit about the varices formation, right? So what would you write? So you would probably start here saying, following Kasai photo enterostomy, this child has shrunken liver, which indicates developing cirrhosis, right? Then you can write what you would write then. Lamai, කියන්නකෝ. This is medicine,
Due to
pediatrics.
cirrhosis,
Yeah.
there is
Yes.
portal hypertension.
How do like they are the point what you have to write a little bit. How cirrhosis causes portal hypertension. This is the pathophysiology part. What happened in cirrhosis in the liver?
Fibrosis and the nodular formation.
Liver fibrosis, right? Sorry, fibrosis and
nodular formation.
Okay, you can write that. So what main important thing is liver fibrosis, right? With the liver fibrosis, what will happen? So liver is replaced with the fibrous tissue, which
Obliterate the spaces of decay.
what are those spaces called?
Space of decay.
Huh?
Decay, right? Decay.
Sinusoids.
Yeah, it's obstruct the venous sinusoids of the portal venous triads, right? So it obstruct the portal venous system or the obstruct the liver hepatic venous system and obstruct the venous sinusoids, right? So then what will happen?
Venous pressure increases and there's backflow to the territories.
Yeah, that's what you have to write. So it causes back pressure on the venous system. So you can further write if you want, because of the contractile nature of the spleen and the gut, which can produce some pressure into the venous system, and other than the arterial push, right? That's a push from the arterial side into the venous system, and liver spleen is particularly contractile tissue, right? So because of this nature, there will be a pressure generation inside the portal veins, right? Inside the portal veins. So what will happen is there will be a back pressure into the portal venous system, right? Then what will happen?
Dilatation of those vessels.
Okay, there will be dilatation of the vessels and it will open up the portosystemic anastomosis, right? So probably that mark would be good enough, right? So when the portosystemic venous anastomosis open up in the lower esophagus, gastroesophageal junction and the fundus of the stomach, they have high chance of rupture, right? So you can write up to that point. What else you would write here? When there's cirrhosis, what happened to the gastric mucosa? What is the particular condition called? There will be cirrhotic gastropathy and chances of erosion will be high. Something else you can write here. Liver is responsible for the formation of
Albumin, sir. Hyperalbumin.
Not albumin, clotting factors.
Clotting factors.
Right? So clotting factors. So the bleeding will not be stopped even in minor bleeding situation and can be continued. Right? Probably that is the answer you would have to write here. Right? Probably that is the answer you would have to write here. Right? So you have to talk about the liver cirrhosis, liver fibrosis, venous sinusoidal, increase the venous obstruction to the venous sinusoidal flow, increasing the back pressure, opening up of the portosystemic anastomosis, right? Gastric, cirrhotic gastropathy, and reduced clotting factors, right? Any questions there?
So what is
Right, okay. Yeah.
gastropathy, sir?
Sorry, what?
So what is the cirrhotic gastropathy?
So cirrhotic gastropathy has several parts. So cirrhotic gastropathy is something that what happening when somebody has cirrhosis. One thing is this gastric vessel dilatation is part of cirrhotic gastropathy. So what will happen is there is a more venous congestion in the gastric mucosal area because of the portosystemic anastomosis. Second thing is they develop gastritis situation with the inflammation of the gastric mucosa following when they have the gastritis, which is combination of both called the cirrhotic gastropathy, right?
Thank you, sir.
Okay, right. The last one. So this is actually a very good question, right? So, right, 5 steps. Action was there is list 5 important steps in the long-term management of this girl. What are the important steps management of this girl? What do you do? What is the single most important step in this management of this child?
A beta blocker like propranolol.
Okay, last bit. So what I'm going to write? What are the most important 5? Like what are the steps you would do? Can you hear me?
Yes, we can hear you.
What would you write here?
So advice and planning a liver transplant and finding a donor for the patient.
What you can write is refer for the liver transplantation. Yes, you have to plan a liver transplantation. Right? Okay, what else?
In acute management, we have to supply the nutrition, fat-soluble vitamins, and
secondary prevention with beta blockers.
Sorry. Right. So you have to plan for liver transplant. Refer for liver transplantation. What is next one?
For the secondary prevention of axial bleeding, beta blockers.
Yes, good. Okay, you can talk about the beta blockers, but what is the more best intervention?
Follow up with human upper ear endoscopy and banding.
Yes, follow up. Yes, very good. Follow up upper ear endoscopies with banding. Right. Then you can talk about the beta blockers. Right. You have to start beta blockers in these type of children to reduce the portal pressure. Right. Next.
nutritional management with fat-soluble vitamins.
What would you say? Only the fat soluble vitamins?